Okay, we are live. Good evening, everyone. We welcome you all to Ortho TV Online, Association of Spine Surgeons of India Pro Series webinar on lumbar disc herniation. I hand over the proceedings to Dr. Gautam Zaveri to take it forward.
Good evening, ladies and gentlemen. It's a pleasure to welcome you on behalf of the Association of Spinal Surgeons of India. The Association of Spinal Surgeons of India, in conjunction with the Indian Orthopedic Association, has planned this series of what are called as the Pro Series webinars, which are directed at the average community orthopedic surgeon. The goal of these webinars is to discuss the basics about pathologies which an orthopedic surgeon or a general neurosurgeon will face in day-to-day practice. Topics such as lumbar disc herniation, lumbar canal stenosis, spondylolisthesis will be discussed in bare detail. The goal is to discuss the pathology, discuss the natural history of the disease, so as to understand how to select the most appropriate patient, discuss the non-operative treatment, and then go on to selection of patients for surgery, the various surgical options, and what is the current concept as far as surgery is concerned. The webinar will be run in a format of interactive case discussion. So you will see common cases, common problems you will see in your OPD. And we have a whole list of panelists from across India who will be answering your various questions and discussing the various cases with Dr. Chabra. You will be asking questions to these panelists through our Ortho TV platform, and the panelists will immediately answer it live. Today, as a special edition, we have two more things. We have a quiz which Dr. Chabra has set. I would request all of you to answer the quiz, and we will give you the answers or provide you the answers as a part of the interactive case discussion. Dr. Chabra has also put up a series of ARS questions which you have to answer and will be like a poll, and we will convey the results to Dr. Chabra and he will cover it forward. So without much ado, let me welcome our President of the Association of Spinal Surgeons of India, Dr. Chabra, who will be conducting the session, Dr. R.C. Meena, the President of the Indian Orthopedic Association, and our panelists, Dr. Upendra from Bangalore, Dr. Sailesh Hadgaonkar from Pune, Dr. Rishi Khanna from Coimbatore, Dr. Arun Bhanot from New Delhi, Dr. Arvind Kulkarni from Mumbai, and Dr. Shankaracharya from New Delhi. These pro webinars will be held every month on a Sunday, which will be the third Sunday of the month at 4 p.m. in the evening. I will be talking about the next pro webinar at the end of the discussion today. So without much ado, let me pass on the mic to Dr. Chabra so that he can welcome all of you.
Thank you, Dr. Gautam Zaveri. Welcome to all of you to this inaugural ASSI Pro Series webinar on lumbar disc prolapse. We are grateful to Indian Orthopedic Association for accepting our request to collaborate for this Pro Series webinars. And Dr. R.C. Meena, the President of Indian Orthopedic Association, who is here with us and who will be welcoming you all shortly, gave some very important tips to us to also discuss how the management changes with the pandemic scenario as we are going through. So very relevant points, sir. Thank you for pointing them out, because the way we practice will probably not remain the same with this pandemic and after also the pandemic finishes. So these points will be also discussed during the webinars. And without much ado, may I request Dr. R.C. Meena, the President of Indian Orthopedic Association, to welcome all participants of this inaugural series of the Pro Series webinar. Welcome, Dr. Meena.
Thank you, sir. Thank you, Arvind. Thank you very much, Dr. Gautam. So, hi, friend. Very good afternoon and greeting from the IOA House of India. On the behalf of IOA, I welcome all the participants in this prestigious webinar series organized by the Association of Spine Surgeons of India. This association has done a wonderful work by disseminating knowledge about basics and advancement of spine surgery in India. In these uncertain times of corona pandemic, where we have cancellation of almost all physical conferences and lockdown have forced us all to stay inside the home and postpone our routine OPD and OTs and indoor works. This webinar series will help surgeons keeping update with knowledge and will keep them engaged with academics. Dr. Rajsekharan himself, a legend and an IO veteran, along with ASSI President Dr. H.S. Chabra, and many learned persons of their own specialty of spines, and their team has put together as an excellent academic program for this webinar. This shall be definitely beneficial to all the spine surgeons as well as orthopedic surgeons in playing their trade, and will appraise them with recent trend management of spine, not only regarding the lumbar disc herniation, but with all spine problems. Friend, my vision for this year as a president seeking perfectionism and excellence in medical education and patient care, which has been put on hold temporarily due to this COVID-19 problem. And this webinar by ASSI will definitely take my vision forward. I really thanks to all the ASSI and learned faculty and the candidate and the delegates of the IO member and the spine member who are viewing this webinar. I wish them all the best and definitely hope they will get some benefit. Jai Hind, Jai IOA, all the best. Thank you, sir.
Thank you, Dr. Meena, for your encouraging words, and we hope we'll live up to your expectations, and we will have a very interactive series which will contribute to knowledge dissemination across India. So thank you. So with this, let me first give me a minute as I load on the slides. Yeah. So we'll have a discussion on management of prolapse intervertebral disc. We have very important panelists, who are experts in management in this field. So we will have an interactive session. We know that prolapse intervertebral disc is a very common problem, especially when you see radiologically a lot of MRIs done across will show a lot of changes, but many of them will be asymptomatic. Many of these have a genetic predisposition, and there are environmental predisposition as well. PIVD represents a degenerative process. There are structural changes which can be result of normal aging, and they may be difficult to differentiate from pathological symptomatic disorders. And the relationship between low back pain and disc herniation is not completely understood. The same with regard to nerve root getting compressed and stretched, and signs and symptoms of PIVD coming up are not especially correlated. Herniations generally would occur at the young age of 30 to 50, and generally prolapsed intervertebral disc has a good prognosis. However, there is a big impact, economic impact of prolapsed intervertebral disc. The total cost associated with low back pain in the United States exceeds $100 billion per year, and the economic burden increases when it is associated with a neuropathic component. So we have a huge impact. Today we'll be discussing various aspects of prolapsed intervertebral disc, whether it is the pathophysiology, presentation, investigations, differential diagnosis, diagnostic criteria, goals of treatment. But there are many questions which are still debated, like duration of bed rest, what actually comprises comprehensive management, how long should we try conservative management, what is the role of ozone therapy, is microdiscectomy still the gold standard, large sequestered fragment, whether to fuse or just do a discectomy, multi-level disc prolapse with failed conservative treatment, which are the levels to be addressed, Poda-equina syndrome with delayed presentations, is there a timeline after which we do not intervene? Do we do laminectomy only or a laminopharomanectomy in Poda-equina syndrome? When do we fuse in a case of prolapsed intervertebral disc? And delayed cases with neurological deficit, should we still go in for surgery? These and there are many other questions that can be discussed. We will see whatever we can discuss within the time available. This is a huge subject, and we have a very interesting faculty here who have a wide experience in this field. Let's start with this case of a 36-year-old male having left S1 pain since 3 months, insignificant back pain, aggravated on bending forwards, straight leg raising of 30 degrees on the left side, neurology intact, has seen 3 different doctors, has been on pregabalin 150 milligram twice a day, methylcobalamin and TENS therapy. He can't walk for more than 150 meters and hasn't had relief so far. These are the X-rays. This is the MRI. So let me start first by asking Dr. Shankaracharya. Dr. Shankaracharya, what is a typical presentation of a patient with prolapsed intervertebral disc?
Well, the typical presentation is that he will have some, it starts with usually with a sudden jerk or some lifting, and he can hear a popping sound. That is an acute presentation of acute disc prolapse. Or sometimes it can be insidious also. And they would present with some buttock pain and posterior thigh pain, depending on the level of disc affected. So if they have an L5 S1 disc affected, it will affect the S1 nerve root, which will be on the back of the calf and the 4th and 5th little fingers of the foot. And if an L4-5 disc prolapse, it will affect the L5, which will be in the lateral aspect of the calves. They usually have leg pain when they walk, and then when they lie down or bend their knees, they get relief. Can be associated with numbness, tingling, and occasional weakness. Most of them resolve, but it all depends upon patient to patient and the type of disc prolapse and where the disc prolapse is, and then the natural course we can discuss.
Thanks, Shankar. So generally, it will present with unilateral leg pain in a particular dermatome, as you talked about, and there may be some associated numbness and paresthesia in the same dermatome, with a list with pain increased on walking, coughing, and sneezing. So this is a typical presentation, as you mentioned, Dr. Shankar. Thanks. Arvind, are there any other ways that patients with prolapsed intervertebral disc can present, or do they generally always present with a typical presentation only?
Yeah, thank you. So they can have a spectrum, the symptoms can spread across a complete spectrum, wherein the patient can just complain of just a patchy pain in the gluteal region, or sometimes patient just has pain in the calf. So anywhere around the dermatome, the patient can have pain, not radiating all the way from top to bottom. Second is in extreme situations, patient can come with a urinary retention, full-fledged cauda equina syndrome. So these are the extreme presentations. And patient can also come with bilateral pain. If there is a large central disc herniation, patient can come with a pain in both lower limbs, according to the dermatome that is affected. It could be L5 dermatome or S1 or L4, depending upon where the massive disc herniation lies.
Thank you, Arvind. They may come with non-dermatomal pain, buttock-only pain. They may present with cauda equina syndrome, bilateral symptoms, back pain only, or just an isolated foot drop or muscle weakness. So they may not present only with typical presentation as Shankar mentioned about. So that we need to understand. So Rishi, will you be able to summarize what is the pathophysiology of prolapse intervertebral disc and what causes the symptoms?
Thank you, sir. So the basic problem in prolapsed intervertebral disc is the nucleus pulposus prolapses out through a tear in the annulus fibrosus. And when the contents of the nucleus pulposus comes in contact with the nerve root, particular nerve root, the patient feels the pain. So here there are two components to the reason for the pain. One is the mechanical compression over the nerve root by the prolapsed intervertebral disc, the nucleus pulposus fragment. Second important reason is the inflammatory mediators. The body reacts to the nucleus pulposus fragment as a foreign body, elicits a strong immune response that results in inflammation around the nerve root, that results in the radicular pain. And this pain can also present with axial symptoms also. Some of these patients have quite a significant amount of back pain along with the radicular symptoms.
So thank you, Rishi. We know there are various aging changes which take place. Vascular channels start to fail and vascular diffusion of nutrients decreases. Thus, the number of viable chondrocytes in the nucleus pulposus diminishes. The synthesis rate and concentration of proteoglycans decreases and proportion of collagen increases in nucleus pulposus. The water binding capacity of the nucleus decreases. Nucleus becomes more fibrous and stiffer, and nucleus is less able to bear and disperse load, transferring load to the posterior annulus. So as Rishi also mentioned that the nucleus pulposus is immunogenic, which induces an inflammatory response, which causes radicular pain syndrome and radiculopathy. So even minor compression creates edema formation and eventually leads to intraneural inflammation and hypersensitivity, and the nerve root becomes highly mechanosensitive. So the endogenous chemicals released from non-neural tissues also increase the nerve hyperexcitability and the susceptibility to compression by a herniated disc. So there are two schools of thought with regard to the disc structural failure. One that the typical one used to be that it is a primary annulus failure, and then came the view and substantiated largely by studies done in the center where Rishi works under the dynamic leadership of Dr. Rajshekharan, where they said it is the primary end plate junction failure which takes place. So you may have also herniation of the nucleus pulposus within the end plate leading to Schmoll's node. So that is in a nutshell the pathophysiology. Let me ask Dr. Shailesh, what are the investigations which can be done and which is the investigation of choice?
Yeah, thank you, sir. When we see a patient who comes to the clinic with complaints of back pain, some of them will complain of only back pain, someone will complain of back and leg pain. When the patients are complaining of back and leg pain, which is not getting better, and we have given them primary medications and still the pain is persistent, the first thing I would like to do is a basic X-ray, because that itself gives a lot of information, whether there is any reduction in disc height, whether there is any foraminal compression, or a lot of things can be seen on X-ray, which is very, very important. Once we see the X-ray, we get the basic idea. We can see whether there is any affection. In the AP X-ray, we always can see the SI joint also. Sometimes it can also mimic some sclerosis in the SI joint. Three things can contribute to discogenic pain. One is disc contributing to the low back, buttock, and leg pain. SI joint can mimic the low back and buttock pain, and sometimes hip also can contribute to a gluteal pain, which can also be important. Most important is clinical examination, and then investigation of choice will be X-ray. And if we are not getting the answer with this, if the patient's pain is persistent and medications are not helping, maybe the choice will be the blood reports and MRI scan.
So thanks, Shailesh. Before MRI came in, myelography used to be the investigation of choice, but nowadays MRI is the one which is the procedure of choice, even though the sensitivity and specificity is not as high as we would want it to be. So now, Dr. Upendra, what would be the differential diagnosis of a patient with a prolapsed intervertebral disc? Are there any other conditions which mimic a prolapsed intervertebral disc?
Most often, thank you, sir. Thank you for getting me here. Most often, it's a clinical diagnosis of nerve root tension we come across. And in the initial 1 week or so, without any significant neurological deficit, we would treat it as an assumed prolapsed intervertebral disc, which is compressing on a nerve. During that period, usually the symptoms come down, and we go ahead with the natural history of the prolapsed intervertebral disc. However, if there are other things that are compressing the nerve root or giving nerve root tensions, it might be a small neurofibroma that is sitting on the nerve, or any other pathology that is actually causing a nerve root tension. So it is important that we rule out red flags first before we say that this patient will go on conservative management. So we need to see that it doesn't have a neurological deficit, a significant one, doesn't complain of any night pains, or history of having some treated malignancy, or a patient over 60 years of age, or younger patient than 10 years of age. So all these come under the category where we probably need to initiate the earlier, so that we need to keep an eye of suspicion. So it is a classical nerve root tension sign. In all these red flags, we need to be and probably diagnose it earlier with investigations.
Thank you, Upendra. Yeah, you can have various other differential diagnosis of a prolapsed intervertebral disc. Upendra talked about neoplasm, malignancy. There could be a meningocele, a Tarlow cyst, a synovial cyst, a scar, an osteophyte, an epidural hematoma, or an abscess. So you can have various differential diagnoses, and you should keep your eyes and ears open. And at the earliest suspicion, you should go in for evaluating it properly. So, Dr. Bhanot, is it just the MRI that we diagnose the case of a prolapsed disc, prolapsed intervertebral disc? What are the diagnostic criteria for a case of a prolapsed intervertebral disc?
So, as Upendra said, mostly in the beginning it is a clinical diagnosis, and in the first few days when the patient presents with a short history and there is no red flag like neurological deficit, I do not recommend even the MRI. But if the patient fails to respond and the pain persists, or there is a neurological deficit, we mentioned that you may need an MRI if things do not settle. So MRI is an excellent tool to diagnose and back up your clinical diagnosis of a prolapsed disc. one more thing which I find in my clinical practice, which is more relevant as a differential diagnosis, is a pathology arising out of hip, because a lot of our prolapse PIVD cases present with mainly gluteal pain. So one should look at piriformis if you do not have a clear sign of a disc problem in the MRI. So that is one area which is common in clinical scenarios. And beyond MRI, usually we do not need anything unless we have to do some special surgical planning.
Thank you, Arun. A very important message. It's not the MRI that you diagnose the prolapse intervertebral disc with. Basically, a clinical diagnosis based on a history and a good examination. And you would use a radiological evaluation only to substantiate that when required and when in suspicion. So the diagnosis is a combination of a good history and an examination, which could be substantiated by a radiological evaluation.
Dr. Chabra, I
Yeah.
have a point to make.
Yeah, sure, Arvind.
So if the patient has L5 pain, most probably it is because of a herniated disc. When you compare between a L5 dermatomal pain and a S1 dermatomal pain, when a patient has a S1 dermatomal pain, you should be wary of things, because sacroiliac joint pain, knee arthritis, especially in elderly population, and some patients with hip problems, they can have pain along the posterior aspect of the thigh and calf. But most often L5 is mostly specific to a L4, L5 root involvement.
Very important that you should not just go on the MRI. You have to see the clinical picture, and like for any orthopedic examination, along with the spine, you need to also evaluate the hip and rule out the hip or the sacroiliac joint also as a cause. For example, if the stress on the sacroiliac joint tends to mimic the kind of pain that the patient is suffering from, then you would probably diagnose it as a case of a sacroiliac joint sprain. So it is a good history, a good evaluation, and as Arvind also very rightly pointed out, we need to evaluate properly in order to make a diagnosis of the patient.
Yes, sir.
So, yeah, Shailesh?
Yeah. I also just want to add to that what Dr. Banod was talking about piriformis. So not necessarily that patient will complain of any fall or significant fall leading to hematoma and piriformis syndrome. In some amount of patient, we have seen it without any injury or history of trauma in piriformis getting inflamed. So that's one. Also, ischial bursa also sometimes can mimic the gluteal pain. That also is sometimes missed, and it can mimic like a L5 root pain. So that also sometimes can be one thing. And in very few instances, we have seen herpetic eruptions causing a very classical radicular pain. That also sometimes we in the practice, what can happen is that we may miss the proper examination of the patient, and we give medications, patient don't get better, and when we see it actually, so that is one very commonly missed thing is a herpetic eruptions, I feel.
Yeah, thanks, Shailesh. Very important point. So we have put this case up also as a quiz, right, Gautam? So this is a 36-year-old male we talked about with a typical presentation of a prolapsed intervertebral disc, no neurological deficit, has seen 3 different doctors, has been on pregabalin 150 milligram twice a day, methylcobalamin and TENS therapy, has not improved and can barely walk 150 meters. You saw the X-rays, you saw the MRI, and now the question which was put across to the participants was, how will you proceed with the management of this patient? Would you advise the surgical management? Would you advise epidural steroids followed by surgical management if no response? Or should it be comprehensive conservative management followed by epidural steroids or surgery if no response? So one of the other options would be give all options to the patient, explaining the pros and cons of each and let the patient decide. So this was one of the quiz questions. Let me ask the panelists what do they think about it. So, so let's start with Shankar again. Shankar, what would you advise to the patient?
I think you have mentioned already that he's had 3 months of conservative pain treatment, and he's hardly able to walk more than 150 meters when he gets leg pain. If that is correct and he's already had this conservative treatment, I will give him a transforaminal root block if he's not had one. And I will give him a steroid. And if he is not taking steroids, I will give him a And I'm quite happy to give roadblocks 1 or 2 and then see the response. And actually, if the response is good and then they get a recurrence of pain, then I'm more happy to go in and offer them surgery if they come back with pain again.
So any of the panelists differ from Shankar?
And the other thing is I would repeat the MR after 3 months. If this is an old MR, then I will always repeat an MR. I always like to repeat latest MR.
So do all the panelists agree with Shankaracharya? If you are silent, I presume you
Sir,
agree.
I have.
Yeah, Arun.
So, sir, this is my observation that the disc herniation morphology like this you have showed, which is a extruded but a contained herniation, it is not sequestered. They are less responsive to transforaminal steroids. They usually come back with higher chances of recurrences of pain. So now I would follow Dr. Shankar's method that I will offer the transforaminal block, but sharing that this patient is less likely to improve and is more likely to go for surgery. So if somebody says, no, I don't want to try transforaminal, if I have a higher chance of surgery, then I would go in for, so that I leave that discretion by giving this information. This is my observation for last several years.
Fine.
Sequestered ones are very, very high chance to respond to transforaminal steroids. So in those sequestered herniations, I usually go in for transforaminal steroids as a definitive treatment. Many a times it works.
Any of the panelists tend to have a different viewpoint?
Dr. Chabra, option B is a part of option D.
Yeah.
So,
okay. So you would, very good.
During the conversation, whatever comes up, I'll go with that.
Right. So other panelists, any other viewpoint?
So for whatever Dr. Arun told, I fully concur with him. The only thing is that holds good for any methods of treatment for a sequestrated disc. So we sequestrated disc to get resolved over a period of time, whether with oral medications or traction or epidural steroids. Right. If it is not improving over a period of 3 months, then definitely it is a contained extruded disc. And at this point of time, the patient, if he's continuing to have symptoms, we may need to consider intervention after having a discussion with the patient.
Fine, thanks. So my specific viewpoint, I would agree with Arvind in that we have to give an option to the patient. Discussing about all pros and cons, it also depends on what your conservative management is. What we discussed as the treatment given to the patient is not comprehensive management as per our protocol that we follow. So we will still offer him a conservative management because we feel that a proper comprehensive conservative management has not been given to the patient, even though it has been 3 months. And many of them respond to our treatment, as also mentioned in a paper that we presented in ESSLS last year and which we are in the process of publishing. Of course, if the patient is in acute pain, wants an early relief, could go in straight for an epidural injection along with the conservative trial, but some of them may say, no, doctor, I've had enough, I want to go in straight for a surgery. So give all options. I would, my viewpoint would be similar to that of Arvind Kulkarni's. And even in literature, they say, except in the case of Cauda-Equina syndrome, the initial treatment could be non-operative. With a high percentage of patients responding to the conservative treatment. And of course, many of them would resolve also naturally per se. Also in the classic Weber's trial, one of the few trials with a 10-year follow-up where there were 126 Norwegians who were followed up. So this was the only trial that has compared surgical treatment of PIVD with any form of natural history, conservative treatment, or placebo. And even if they went through surgical management, it difference was there. After that, the outcome was basically similar. However, if the patient is incapacitated and the quality of life is being affected, the first 2 years are also very important. So you need to take that into consideration. There have been some criticisms of this trial, which we'll not discuss about in the interest of time, but we will come back to this subsequently. So let's talk about the goals of treatment of a case of prolapse intervertebral disc. So, Arvind, what would your goals of treatment be for the patient?
So we need to treat the patient symptoms. Basically, patient has leg pain, patient may be having some degree of paresthesia and weakness. So in early, patients who tend to get operated early, we can promise a bit more with regards to numbness and their weakness, apart from the pain. The latecomers, we can't address most of the complaints except the pain and discomfort. So the time zone varies from paper to paper.
Right.
In those patients who have neurodeficit. So, but the most common presentation is that of pain and discomfort. That is the thing.
Anybody from the panel, any other goals of treatment?
Improve the quality of life after the pain is relieved.
Good, Arun. Any other point?
To go back to activity of daily living.
Very good. Any other point? So the goals of the treatment, early return of patient to their normal activities, right? So of course, pain relief is there. And one of the other goals could also be to avoid unnecessary surgery. You know, when prolapse intervertebral disc management, surgical management came out, people went in for surgery in all the cases. And in one of the initial studies of 1947, when they started 170 surgical cases, the outcome was very dismal, mainly because all cases were being chosen up for surgery per se. But in another study done in 1986, when they had strict objective criteria for surgery, they were very good outcomes. So you need to choose your cases for surgery very well. Also, you should understand that if conservative management has failed, if you delay the surgery also, then also the outcome would not be good. So you have to plan very well. One of the other goals of treatment would be efficient and precise use of diagnostic studies and to devise a treatment format that will make therapy available at an acceptable cost to the society. So those in a nutshell would be the goals of treatment. I hope the panel agrees in this regard.
Sir, I also believe what Dr. Shankaracharya said, that conservative followed by 1 or 2 blocks, and because it's unilateral disc, and if the patient is demanding, then yes, of course, surgery. But I just want to ask the panelists, how many of you are doing the sacral epidural, the caudal epidural blocks, and how many are doing the selective nerve root blocks? Because I personally do selective nerve root block or transforaminal, but just want to ask.
Shailesh, we come to this question in a while. We'll have specifically asked.
Sorry to interrupt here, Dr. Chabra. We had a poll on the first question about what will be your next line of management. None of the participants, we have close to 2,000 participants watching us right now, and none of them voted for surgical management or epidural steroid at that point. 33% of patients said that comprehensive conservative management followed by epidural steroids or surgery if no response. But 67% of patients participants have said give all options to patients, explaining the pros and cons, which was your answer.
Great.
Hello.
I think that's down, I think.
Yeah, I can hear you, Gautam and Upendra.
Yeah. But only
Chabra's connection seems to be interrupted.
All right, we'll wait for him for 1 minute. Otherwise, I'm going to take over.
I cannot see Dr. Chabra. Where is he gone?
Yeah, probably.
In the meantime, Dr. Chabra is figuring out. I would want to talk about the conservative management. Is it okay?
Yeah, please do.
So the issue is, when we talk of conservative management, we say this has not been done properly or this protocol has not been followed. But I think the main aim of conservative management, or how it works, is providing time for natural evolution of disease to settle.
Yeah.
So it is more of a pain medication during the time of this natural healing, which we are biding. And whether you do X, Y, Z, A, B, C, it is the time factor which permits the patient to come out of the acute painful phase.
Exactly, agree with you. See, the natural history, if herniated disc has to resolve, it would resolve by itself the first few weeks.
Exactly.
So if it is not resolving, probably it will not resolve with any of the conservative managements. So that is why I think all over the world now, if the conservative management is not working and it is a typical disc that is compressing on the nerve, I think after 4 to 6 weeks of trial, I think you should offer the patient the option of surgery because
or
it
some
will
kind
be,
of intervention.
Yeah. Yes, absolutely.
Sometimes, Upendra, you see, I have patients who for a long period of time don't want surgery. You have a large group of population who don't want surgery. And I can show you that at least from the large group of this population who don't want surgery, who have a contained disc, they actually resolve over a period of time. So while we may say that it is 3 months and we may say that it is enough to go ahead and do surgery, patients are reluctant. They don't want surgery.
So
And
Absolutely. It's their decision. It's our duty to inform them.
How the patient looks after his back is also important.
Absolutely.
If he starts some exercises, strengthening, he manages himself. And I've seen a lot of patients manage themselves well, even with a contained disc for quite a long time. And then the natural history takes place, and it sometimes may be longer than 3 years.
Patients have gone back form of Ayurvedic treatment or some completely relieved. We have advised surgery. They have come back after 1 or 2 months completely normal. So it's our duty to give them the information and be transparent with them, and also say that, you know, anything can, but at this point of time, these are the options you have.
So my point was that it is not the type of conservative treatment, it is the time given for conservative treatment which actually works.
But
only
time is not the factor.
And the rehabilitation that the patient does, as you mentioned, that will give him some strengthening and quality of life changes. So a lot of such patients who refuse surgery do get better, as you rightly said. We all see them.
What happened to Chabra?
I think it's internet.
What is your views on these epidural injections, either interlaminar or transforaminal block? Because they work on the premise that they block the inflammatory component, which is usually maximal in the initial 6 weeks duration. So this patient has crossed 3 months duration. Now, how do you think these blocks work?
Probably in this patient, if he has a sudden onset of recurrent pain, it might be a small, a fresh annular tear which has caused, which is again amenable to a transforaminal injection because there will be increase in the inflammatory markers there. So we have to carefully see his history. Is it a constant pain that is occurring, or just few days back his pain has increased? So which probably is, a fresh annular tear, which is again causing a chemical irritation. I think that will help. So probably we have to see this patient with much more clearer history here.
But there is another mechanism, Rishi, that can work even when there is no acute inflammatory response, because once the nerve root has been sensitized and it remains painful throughout the 3 months, if you break the cycle of pain by desensitizing that nerve once, sometimes you can get a good pain relief for a reasonably long period of time. That's the only way it may work.
Yeah, I think Dr. Chabra is back.
Dr. Chabra is back, yeah.
Yeah, sorry for that interference. Now, my next question is, how many days of bed rest would you advise in this patient if the patient comes to you? 3 days, 7 days, 14 days, 30 days, or would encourage the patient to stay active within the limits of pain?
Yeah, that's...
So can I ask Upender?
Yeah, I mean, thank you, sir. We would always advise the patient to within the limits of the pain. Now, there is not much evidence that if we put the patient to bed rest, it's going to do any benefit. In fact, probably it is going to do some harm, because once they get up from the bed with a complete bed rest, they will be loading the spine suddenly with loss of all their protective reflexes, which can actually increase the of their disc popping out again. So nowadays, we do not advise anybody to strictly stay in bed. Initial 1 or 2 days, whenever they have very severe back pain, yeah, I mean, they can be on bed as and when they want, they can get up from the bed within the limits of the pain. We would advise them not to bend forward, not to sit in Indian toilet, not to sit down, bend forward, or lift weights during. But here, was it for this patient, sir? Would we advise?
Yeah, this patient, for example.
This patient, after 3 months, I don't think there is any role of bed rest here.
Right. So anybody from the panel differs?
No.
Everybody agrees.
So in this patient, there's no role of bed rest, but generally, my advice would be A followed by E. In a patient who comes on day one.
Right. Okay, so as Upendra said, bed rest, there is consensus that bed rest should be limited to no more than 2 to 3 days. In fact, you could advise the patient to be as active as possible. And the Cochrane study also suggests that we should prescribing more bed rest than is required is counterproductive per se. So you would advise the patient to be as active as possible. Now, my other question to the participants has been, what comprises a comprehensive conservative management of prolapsed intervertebral disc? Whether it is heat or ice, local counter irritants, pharmacotherapy, physiotherapy, exercises within the limits of pain, or all of the above. So let me take the panelist viewpoint. Do you have any particular conservative management protocol? Are you aware of any standardized conservative management protocol so far? So let me ask Shailesh in this regard.
Yeah, I will consider all of the above because it's a type and subtype of patient, the demands of patient. Some patients feel better with cold compress, local counter irritants. Even gabapentin works well in a lot of patients. We have to explain them that there can be some kind of dizziness or sleepy feeling in 5 to 7% of the patient if they take pregabalin or gabapentin. And maybe a TENS, if there is radiation or IFT, will be very good. Initial part when it is acute pain, there is a good chance. I will avoid exercises in acute disc, but if the patient comes at 3 months, definitely that can be considered. And exercises, we can just avoid too much of stretching and bending exercises. Just simple basic core exercises can be done.
So Rishi, would you tend to agree? Do you have any other viewpoint? Are you aware about any standardized conservative protocol which has been published so far?
As such, there are no standardized protocols with regards to the particular medication, because a lot of studies have shown that oral steroids work in some patients. In some studies, it has been shown that they don't work properly. Similarly, NSAIDs, pregabalin, gabapentin too. But in our center, we have a standardized protocol. The 2 groups of patients, one who present acutely within the first 2 or 3 weeks, for those we advise an initial 2 to 3 days of bed rest and oral NSAIDs along with pregabalin in increasing doses. Like initially, we start with 75 milligram at bedtime and then increase it twice a day up to a maximum of 300 milligram in a day. And again, within the first acute episode, we don't advise exercises and make the patient mobilize as per the pain limits. But considering this patient, I think has crossed the period where bed rest may not work for him, and again, NSAIDs may not be helpful. So at this stage, if he opts for a conservative line of treatment, it would be mainly neurotropic agents and spinal flexion exercises.
Fine. Anybody from the panel has any other viewpoint? Do they have any other standardized protocol of conservative management?
Sir, I just wanted to make a
yeah,
people are viewing and Rishi also mentioned that the route of steroids. I mean, a lot of people do use oral steroids routinely. I think it's not a standard practice to use oral steroids in all these acute disc herniations. Because one of the problems is like whenever we prescribe, we have seen that do not stop it. That is the main concern. And also there have been no studies that have proven that oral steroid is actually benefiting in the acute setting. So that is one point I just wanted to make.
Right. Anybody else? Any other viewpoint? So,
Dr. Chabra, just to give you an answer on the poll,
yeah, Gautam.
how many days of bed rest would you advise? About 25% of the people said 3 days of bed rest, whereas most of the people, that is almost 80% of the people said would encourage to stay active within limits of pain. Nobody voted for 7 days, 14 days, and 30 days.
Great, great. So glad that everybody
so
is in line with it.
Yeah. What comprises a comprehensive conservative treatment? I think almost 100% of the people said all of the above, which included local counter irritants, pharmacotherapy, physiotherapy, and exercises.
Great, Gautam. So I'm glad everybody is aware about the evidence which is there in this regard and concurs on what should be the duration of bed rest and what should be the protocol of conservative management in these cases. So, in fact, I mentioned about our presentation in results and our conservative protocol, which we are in the process of publishing. So it is a multimodal conservative therapy, basically all of the above as mentioned in the previous slide. And if the patient doesn't improve, we go in for transdermal epidural steroids. And if they don't improve, we go in for a surgery. When it comes to pharmacotherapy, we differ a bit from the protocol which Rishi mentioned. We go up to 600 milligram of pregabalin also, if the patient can tolerate it well. We start with 75 and gradually increase it because people can have drowsiness and giddiness. And if they have drowsiness and giddiness, we would reduce the dose and add oxcarbazepine or gabapentin depending on that. So some people respond better to pregabalin, some to gabapentin. If they don't improve, we would even add duloxetine up to 120 milligram gradually, amitriptyline also. Upendra, we found some studies which mention about oral and intravenous methylprednisolone, and we have been using it, and we counsel them that it has to be taken as mentioned only. So there may be a difference of opinion in this regard, but there are published studies in this regard, though we do not have a level 1 evidence or a level 2 evidence for any conservative protocol for prolapsed intervertebral disc. We compared our results with the outcomes of other long-term studies, and we found that we had better, if not equal, results with the Weber, Main, and Sports trial, whether it was for back pain, radiating pain, patient satisfaction, or functional outcome. This study was done on 403 patients of prolapsed intervertebral disc. And we would want to mention that only 5.4% of these 403 patients required a surgical management. Most of them responded to our conservative management per se, and this was amongst the best as compared to the other studies as well. So people do have different protocols. So we have to come to a consensus on a standardized conservative protocol. Some of the proven treatments for back pain and prolapsed intervertebral disc are patient education, to educate them. Like Upendra said, they continue with the treatment. No, to tell them how to manage their problem themselves and to mention about the post-operative reduction of risk factor, post-management, post-acute pain reduction of risk factors, etc. Aerobic physical conditioning exercises have been found to affect the natural history of the disease, and you aim also at removal of predisposing factors through general physical conditioning exercises, and emphasizing on proper posture is very important. The next question that I have for the panel is, what is the role of traction? So one of the panelists mentioned about traction previously. So let's move across to Arvind. Arvind, what do you think of the role of traction in management of prolapse intervertebral disc?
I think traction is history now.
Right.
So the main reason we put patients on traction was, they would, when we advise bed rest initially, they won't stick to their bed, they would sit up. Flexion is worst for a patient who's advised bed rest. So now the question of bed rest itself is not popular. So it is all, as I said, historical now.
Right. So anybody from the panel has a different viewpoint?
There is an MRI-based study with the use of traction and performed in an MRI console with patients who had lumbar disc herniations. And they observed with increasing weights, they're able to demonstrate shrinkage in the size of the herniation. But actually, in clinical scenario, we don't prescribe traction alone for patients. When the surgeon or the physician treats the patient, he uses a combination of modalities. So we don't know which actually works. But we, in principle, believe that traction helps the patient to keep in bed for the initial few days. That's all.
Yeah, Rishi, was that study a level 1 study or was it a level 4 study?
The K series, a level 4 study.
K series only. So you cannot rely just on a one-off study. You have to have a meta-analysis before you draw a conclusion in this regard. In fact, there have been various studies at various associations which have mentioned about little evidence to support the continued use of traction in the management of back pain and disc prolapse. But they also mentioned that despite this, a large number of people continue to advocate traction for the management of the patients. In our experience, we find that some cases the pain increases with traction. So we always tell our patients, in case your therapist convinces you to go in for a traction, if the pain increases while on the traction table, immediately ask him to remove the traction, and intermittent traction is the one. In fact, what the role nowadays, if there is any, is more of auto traction, where the patient himself determines with the use of gravity how much traction is being put, so that if there is pain, the patient listens to the call of the body per se. So similarly, role of chiropractic manipulation. So anybody from the panel, Arun, what do you think? What is the role of chiropractic manipulation?
So before, when you were disconnected for some time, we were talking about how conservative management works. And in my personal view and observation, it is most of our conservative management treatments rely on natural evolution of the disease, because our drugs, our physical therapy treatments, etc., they cannot reach that depth of the problem where the disease is. So you are relying on natural evolution of the disease while keeping the patient comfortable, and that is how your conservative treatments work. So chiropractic manipulation may also work transiently in relieving pain if they dislodge the fragment which is sticking to the nerve, if it is a small one. But then it has to be done very expertly, and it should not be taken lightly. I haven't prescribed any patient for chiropractic manipulation, but I do come across patients who have seen a chiropractic, and some of them do tell that they get better.
Yeah, Arun, there are very few trained chiropractors in India as opposed to US, where chiropractic is a branch in itself and people are trained to do that. So in India, I think we should beware of, because there may be a few of them who've been trained abroad and have come back. But we should be beware of any self-styled chiropractors who start the treatment on their own.
Can I make a point here?
Yeah, sure.
I think the role of pelvic correction or manipulation is there in sciatic scoliosis. And I have had a disc prolapse and I have had sciatic scoliosis. And I have seen a lot of patients where you have a good physiotherapist who knows what he is doing. And if he corrects your pelvic tilt or manipulates, I think the scoliosis disappears and your pain disappears also. So how it works is probably by unlocking the facet or relieving the spasm or something like that. But it works in combination. So you can't do alone. So you have to do some exercises and things. And I've seen this. I think you know this Muller who's there in South Delhi, or in Nizamuddin. And I've seen him correct scoliosis with significant relief for these patients. So there is a role of manipulation in sciatic scoliosis in an acute disc, which becomes chronic in for about 8 weeks, 10 weeks, 12 weeks, and they don't seem to get straightened. And so this seems to work. At least I've seen some patients.
So that's what, Shankar, we talked about. Trained people, trained chiropractors rather than self-styled chiropractors who start practicing on their own. It may have a role per se. So now, Shailesh, one of your questions was what is how many people opt for caudal and how many for transforaminal? In fact, people used to practice interlaminar also. So, let me ask from the panel, Upendra,
Yeah.
what is the evidence, right?
Yeah, now we have to see why we are offering injection also. So it is basically to relieve the nerve irritation by the chemical mediators. So the chemical mediators are in the ventral epidural space. So the best method would be to deposit the steroid in the ventral epidural space, which is done by the terminal route. Yes, the interlaminar route used to be done before, where the results were not that. Now you have evidence that the transforaminal steroids nerve root block is much more beneficial than an interlaminar injection for a specific root by a herniated disc. Caudal epidurals, it is more of a diffuse, epidural injection where you use a lot of volume from the caudal end of the sacrum. It doesn't go to the actual area of inflammation. So it is only used by when the patient has used, multi-dermatomal pains in our practice. So in our practice, it is mainly a transforaminal root block to the affected nerve root, which has given us some relief for the patients. And that is what we use.
So anybody from the panel differs?
One thing to add is if the patient is having a unilateral radiculopathy due to herniated disc, we give a transforaminal block. And if it is a bilateral pain due to a single or a multiple level disc, then we advise the interlaminar epidural steroid. Caudal, we don't use it in our practice.
Yeah. I think why trans-selective root blocks came into vogue, transforaminal blocks came into vogue, was that with interlaminar, there was a slightly increased predisposition towards arachnoiditis. There is a big group of patients who harp about arachnoiditis with epidural injections. That was mainly when there were oil-based steroids which were used before. So we have an option now not to use oil-based steroids, and the incidence of arachnoiditis is less. But in order to avoid any chemical reaction, it is best if you can give selective root blocks, and you can put in a contrast and you can demonstrate that you have hit the right nerve root. So those are in vogue. Though when I was in the ISSLS meeting, there were people who talked about caudal epidural mainly because of the ease of administering it even in the outpatients and with the quick relief that can come to that, whereas a selective root block would need to be given under CM guidance. So some people are still advocating caudal epidural block. So anybody from the panel who has any point to make? So there are various questions. How many? What is the exact amount of steroid? How many times would you offer it? What is the ideal time between two blocks? So when we did a literature review, we found that the best results would come with not one, not two, but with 3 epidural blocks. And so around 15% of those who fail a good conservative treatment would improve with 1, long term, not short term, long term. 35% with 2 and 60% with 3 selective epidural blocks. They will get long-term relief, and surgery could be obviated in this regard. And we give them at weekly intervals. And we would put in a contrast and localize and ensure that we would hit the right nerve. And so there is evidence that they do work. Now the question comes, one of the very popular question which comes is, what is the role of ozone therapy? So would Shankar, would you want to respond to that?
I can respond to that. Having said that, personally, I have to say that personally, I have no experience on ozone therapy, but in my hospital, our pain physicians or anesthetists do a lot of ozone therapy. Still, I see mainly the complications, so I have a bias towards it because it can cause discitis, it can cause more severe pain, and it does not resolve the sequestered disc as well. So there are issues, but they say that 15 to 20% of their patients do well, and it is the philosophy is that they always it works with that super radical oxygen, which apparently does lysis of the disc fragment. And also they always use steroids. So I always counter their argument with that, saying that if you believe that ozone works so well, then why you use steroid along with it?
Anybody from the panel? Yeah. Shankar, please go ahead. Yeah, Shankar, you wanted to say something?
I just want to say that it is still a popular method with a lot of patients because a lot of patients don't want surgery. So they do go for these ozone therapies.
So do the pain physicians at your center believe that ozone works better than epidural steroids?
Yes, they do. No, they don't give epidural. I mean, they don't do caudal anymore. Most of the pain physicians also do transforaminal root blocks, or if they think there is a facet arthropathy, they would do a radiofrequency ablation. But they do give ozone in about 15% of the patients.
So,
Dr.
Chawla, the natural history of this disease is very well known. See, 90% of them, the nature helps. So if you see Rothman's, there is a saying, there is a statement, the natural history of this particular disease is altered only by surgery.
Right.
So when this 90% of them where they're blessed by Ganga, so everyone takes a dip in this Ganga and becomes the takes credit for resolving the patient's pain. Exactly. When the patient is getting better on its own. I've seen patients who have undergone ozone, they are drugged like crazy. Tons and tons of gabapentin, kilos of steroids, and bed rest for 2 to 3 weeks following ozone. I've seen all this. This is I don't think we should even discuss this therapy.
Arvind, Upendra, you wanted to say something? Go ahead, Upendra.
Yeah, I think all intradiscal procedures for a herniated disc needs to be seen in a different light, because intradiscal procedures can only address inside the disc, and with the that they will bring in the herniated fragment inside. And there have been a lot of evidence that not work, and maximum they have been working where there is a slight protrusion, where probably anyway it would have resolved as such. So all these intradiscal procedures, I think we have to take it with a pinch of salt, and from the dais of ASSI, I should not go ahead and recommend it as such.
Absolutely.
So we did a literature review also. Yeah, Arun, I'll just come to it.
So my point is, in my OPD, when I treat a patient, I tell them that if I am not operating you and you are getting well, my contribution is only surgery. Rest everything is your disease and your natural evolution. So whatever done short of surgery is actually relying on natural history of the disease. That is exactly what I tell. Whether you give a steroid, whether you give a ozone, whether you give a particular kind of physical therapy, this is my standard practice.
Yeah, when we did a literature review, we found out that it's not only intradiscal ozone that they recommend, they also give periganglionic selective root blocks, and also in the muscles. So there are various schools of thought for use of ozone, but none of these have been able to claim any results better than epidural steroids. And epidural steroids have been time tested since ages, and there are perhaps tons and tons of publications on epidural steroids, maybe more than surgical management. So people may want to use ozone therapy. There's some evidence, but there's no evidence that it is better than epidural steroids per se. Also, Arvind, just one a point to add to your statement. When we did a literature review, we found that three things could alter the natural history of prolapse into vertebral disc. One is surgery, the other is patient education, and the third is aerobic conditioning exercises. So all these three, rest all do not alter the natural history of the disease. They only act temporarily per se. So now coming to the question again, what are the indications for surgical management? So could one of you, Shailesh, could you respond to this question?
Yeah, my indications will be first is that neurodeficit. If the patient comes to me acute pain and there is a neurodeficit, progressive neurological deterioration, that is my first indication. Cauda is definitely associated. That's again my prime indication. Cauda neurological deficit. Persistent pain with a large extrusion, sequestration, and severe compression, which is not responding to conservative treatment, is again my indication. At 6 to 8 weeks, if the patient is with persistent pain, not been able to do activities of daily living, medicines are not helping, all these things have been tried, he is my candidate for surgical indication.
Right, Shailesh. So increasing neurological deficit is one of them. However, Weber had used these also patients for his conservative treatment. Significant neurological deficit, this is another indication. So some people even advocate conservative treatment for this. Cauda equina is the only absolute indication for surgery. We all concur on this. But the most important and most common reason is failure of conservative treatment, as also mentioned about by Shailesh. So we'll come to that. What is the period of treatment? So absolute indication, there's a consensus. But on relative indications, it depends more on the threshold of the patient and the threshold of the surgeon per se. But it has been clearly proven that discectomy has stood the standard of time through various trials. The sport trial being one, the Lumbar main study also showing good results, at least in the short-term follow-up. So there's good level 1 evidence in favor of discectomy. There's also level 2 evidence in favor of discectomy, though many of them say that long-term results do not differ. But the medium-term clinical outcomes have been sufficiently consistent for discectomy to survive the test of time in widespread clinical practice for more than half a century. So anybody has any other indication for surgical management, or the panel concurs?
Yeah, can I
Yeah,
have a
sure.
word, sir? Regarding neurological deficits, if there is a significant deficit, say it is 2/5 of EHL also, there are significant studies now showing that surgical intervention will actually improve the significant neurological deficit by around 70 to 80%. All the previous studies before 2000, where we quote Weber and all, they told that conservative management or surgical management, the recovery of your neurological deficit was around 30%. So both were same at that time. That is why we have been brought up with the idea that surgical intervention does not have any role in improvement of a significant neurological deficit.
We will come, will come to questions with regard to cases with neurological deficit. We have a set of questions on that. So we agree that neurological deficit.
I understand correctly, Upendra, are you saying that painless foot drop, complete neurological deficit, you say that there is now enough evidence to suggest that in painless foot drop, you should do surgery and there will be improvement?
Shankar, we'll come to this discussion. We have some, because this is also points in favor and against this, but only point is whether just an EHL weakness with no abductor weakness, if the patient doesn't recover, is it going to change the lifestyle of the patient per se? That we could consider. Now, One of the other quiz that we have given to our participant is what is the optimal duration of trial of conservative treatment before suggesting surgery or epidural steroids. 6 weeks, 3 weeks, or may vary from patient to patient. So let's
To that,
hear from the panel. Yeah, Gautam.
the audience has responded that it may vary from patient to patient.
Great, great. So, the panel, do they have any specific opinion in this regard? Let's hear from Arvind. What do you have to say?
I would say 3 weeks, So at so I actually basically look for the trend. I don't look for the pain per se. If I look at the pain, I ask the patient what is the trend of the pain been? If the trend has been that of a plateauing, or if it is increasing at 3 weeks, I advise steroids at that point of time. If they feel that it is getting better, at that point of time, I just continue, allow them to continue with their physio and on and off medication.
So it will vary from patient to patient, right? Hello.
Yes.
Yeah. Shankar, any other point of view?
No, I think it varies from patient to patient. Yeah. But by 12 weeks, I tell the patient that if you delay further and your pain is significant, the nerve may have some memory and you may be left with some residual pain. That's all I said to tell them. But otherwise, it varies from patient to patient.
Yeah, in our practice, we feel that our conservative protocol within 2 to 3 weeks, we come to know whether he will respond to the conservative protocol or not. Then we would advise them epidural steroids. But some patients, we increase the dose of medications faster if they need to get back to a normal lifestyle earlier. So then even if we go through the whole process of the comprehensive conservative protocol and 3 epidural steroids, within a month we will be through with everything, and we would go either for a surgery or the patient may get relief. So even in studies they say failure of conservative over 6 to 12 weeks, then you would go in for a surgery. And there are some studies which mention that if you have them wait for more than 12 months, it has a less favorable outcome. There are some studies which show that early or late surgery do not make a difference. So there is no consensus in this regard what duration, but as the participants also rightfully mentioned that it may vary from patient, and that's the opinion of the panel as well. Now, if you go in for a discectomy, right, Arun, what is the optimal amount of disc to be removed during this?
So while doing discectomy, my primary aim is to remove the herniated fragment which is lying in the epidural space. Besides that, you would definitely want to look in the posterior annulus and search for any lurking fragments which are loose and likely to cause an early recurrence. But I do not go in for any radical discectomy like trying to clean up most of the disc to avoid a chance of recurrence.
Yeah, so there are clear-cut evidence that if you try to remove more discs than required, then the sequestered fragment, it has an adverse outcome and more chances of long-term back pain continuing with this patient. So you should remove only the sequestered fragment or the fragment which is bulging out or the degenerative fragment, and you should not tamper with the normal disc per se. Now coming to this important question, I think within our panel also we will differ on this. We asked to the participants what is the optimum technique of surgical management if the patient needs a surgery: microdiscectomy, endoscopic discectomy, traditional open discectomy, or any of the above depending on surgeon's familiarity and preference. Gautam, do we have an answer for this from the participant? Meanwhile, let's ask the point of view. Rishi, what is the evidence in this regard?
So, there are multiple studies comparing, even randomized controlled trials comparing microlumbar discectomy with endoscopic discectomy. There have been differences in the initial short-term outcomes, but over a period of time, like 6 months and 1 year, outcomes have been fair between both the groups. So I don't. It's the surgeon's preference to select the appropriate technique. The aim is to decompress the nerve root.
So D is what you are mentioning about, what the surgeon is familiar with. So that is.
I am
So
comfortable.
Arun,
Yeah.
Arun, do you agree?
So exactly, a surgeon has to deliver a good on the surgery he is doing. Most of the techniques, if done well, they will give reasonably similar outcomes. But at the same time, when we talk of efficacy of a surgery, it also needs to be looked into the aspect of what is the degree of complications that the surgery is likely to create. So recently, just about a few months ago, there is a paper, a network meta-analysis, which was a huge meta-analysis published in European Spine Journal, which talks of comparating complications in various surgical techniques. And in that, they have found that the risk of durotomy, which is the most likely complication intraoperatively, and other complications compared between microdiscectomy, MED, and endoscopy. Endoscopy does tend to come on the lower side of complication curve. So I'll be talking about this in my presentation, but this is my observation. But having said that, it has to be the surgery which the surgeon, treating the surgeon, can do good. A badly done established surgery can also lead to havoc, and a well done surgery, even if a new technique, can give excellent outcomes. So it is surgeon dependent.
Arvind, what is your opinion?
Yeah, I agree with Bhanut. So most of the minimal access surgeries, you need skills, and it takes there's a big learning curve for these minimal access techniques. And if you compare at a state where the surgeon is still learning, you'll tend to have a lot of complications. In a well-established surgeon who does endoscopy, if you compare him with the one who does a tubular discectomy, you compare them with the person who does the open laminotomy discectomy, I don't think the results will vary much, except for the collateral damage that the open techniques can cause compared to the minimal access techniques.
So Shankar, any level 1 or level 2 evidence in favor of microscopic or endoscopic discectomy?
I think traditionally it used to be all discectomies used to be compared with microdiscectomy, and that was considered gold standard. But however, as Arun says that the collateral, or Arvind says that the collateral damage, which I don't think is much. I think a well done microscopic discectomy is as good as a tubular discectomy, and the incidence of durotomy may not be significantly higher in these as well. Having said that, I think surgeon's expertise is probably the most important thing in preventing collateral damage. So if you have learned the skill of an endoscopic discectomy, yes, good. But for most of us, microscopic discectomy still has good level 1 evidence that it works well.
So there were 3 trials which compare between, we do not have a good level of evidence, but we cannot go solely by evidence also, because there have been no long-term trials in this regard also. So whatever the surgeon is more familiar with, there have been trials which they have tried to monitor the EMG as a marker of nerve root irritation and also collateral damage. And it is propagated that since you, in a tubular discectomy, you violate the normal anatomy less. So post-operative rehabilitation is good. There is lesser, smaller incision, but the surgeon needs to be familiar with. If you look into minimal invasiveness, the requirements of a surgery, minimal invasiveness, technique, operating time, diversity, cost, outcome, complication rate, when we compared the literature, probably the tubular tubes stand out, right? Whether you use a microscope with it or whichever way you do it. So they stand out, but it is what the surgeon is familiar with, which is more important. So we will now have Rishi demonstrating fenestration discectomy. Can you put on your, share your screen, Rishi?
Yes, sir.
Dr. Chabra, you'll have to unshare your screen.
Yeah, I have unshared.
Right. Rushi?
Yes, sir. So I'll just go through the initial few steps of fenestration discectomy through an unilateral approach, assuming it is a L5S1 disc prolapse.
Rishi, we are still seeing Dr. Chabra's screen. We are not seeing your screen.
Yes, just started screen sharing it.
Please let me know, sir, when it is seen, because I already shared my screen.
No, it is not being seen. We are still seeing Dr. Chabra's screen. Dr. Chabra, you'll have to write over, go over
Yeah,
there
yeah.
and share your screen.
I have unshared. Welcome.
We are not seeing.
On the Ortho TV, it is Rishi's screen which is showing.
Yeah. I have unshared.
The Ortho TV link is showing Dr. God. Now it is showing.
Now we got Rishi.
Yeah.
I think one of the people had not shut themselves.
We give a general anesthesia for the patient, and one important step I would like to highlight is to give the preoperative intravenous antibiotic at least within 45 minutes of the skin incision. Another important stuff is to check the level and site of the pain before you proceed to mark the level and proceed to go ahead with the surgery. A lot of times we have seen patients can end up having a discectomy at the wrong level or on the wrong side of the surgical site. And for the position of the patient is placed prone, and to have a obliteration of the lumbar lordosis, we can use multiple equipments. Bolsters can be used, the Wilson frame can be used, or a knee chest position can be used. And we generally use the Relton Hall frame. So this Relton Hall frame is a equipment which is easy to use. It helps in obliterating the lordosis, and the abdomen hangs free so that there is no pressure over the intravenous cava. So we don't have engorgement of veins during the surgery. And make sure that you protect all the pressure points while positioning the patient. Protect the eyes. Pressure on the eyes resulting in blindness is one of the rare but catastrophic complications. And once the patient is positioned, give a good scrub, and we have to mark the skin incision before we proceed with the surgical exposure. This skin incision marking is very important because we are going to use only a narrow 2.5 to 3 centimeter incision. And another thing is, for using a microscopic discectomy, we are going to use the microscope through a narrow window. So it's easily possible to skip through the scheme incision to an adjacent level. So if you can see in this situation, so if you angle the microscope, you can go to L4-5. If you have angled it cranially, and if you have angled it caudally, you can land up at the L5S1, which could be the wrong level. And in the lateral view, you can see that the orientation of the disc is different at different levels. L3-4, it's almost perpendicular to the floor level, whereas at L4-5 and L5S1, you have an angle. Our aim is to enter through the interlaminar space between the two spinous process. So you can mark a level between the two spinous processes and then proceed straight to the interlaminar. And it is possible to skid into a wrong level, especially when you have a sacralized lumbar vertebra. So don't just go by the numbers alone, like an L4-5 disc or an L5S1 disc. Always in the C-arm picture, what you are seeing should be matched by the sagittal MRI image. So whichever level is the second disc space, that's how we proceed while exposing the patient. This will be the standard surgical steps once we mark the level. So we make a 3 centimeter incision. We do a paraspinal unilateral exposure to reach the ligamentum flavum. In L5S1 level, we can straight away proceed with excising the ligamentum flavum. At proximal levels, you may need to do a small laminotomy to extend the bony window to see the neural structures. Once the flavum is excised, we have to identify the neural structures. So the thecal sac and the nerve root. And within the nerve root, the shoulder of the nerve root and the axilla of the nerve root should be clearly visualized before mobilizing the nerve root. In a prolapsed disc herniation, you'll have a lot of engorged veins and adhesions around the nerve root. So make sure you retract the nerve root adequately to identify the disc, herniated disc, if it has been already sequestrated, or if it is a contained and extruded disc, you can see the bulging annulus. And once the annulus is very well visualized, you make a annular incision. This can be a vertical incision along the line of the nerve root, or it could be a cruciform incision. Then we proceed with the discectomy. And at the end of the discectomy, we make sure the nerve root is adequately decompressed, because the entire surgery is not just a discectomy. The main goal of the surgery is to have a good nerve root decompression. Then we wash and then close the wound. Now we proceed with the video demonstration. So this patient had a history of low back pain with right radiculopathy. The radicular symptoms have been for the last 1 month, associated with numbness in the right foot. And as you can see in the sagittal and axial MRI images, there is a huge paracentral disc on the right side. So as I said earlier, we have marked the level. You can see the needle marking the level. The level where we have marked this skin incision, we make a 3 centimeter long skin incision. So we are given an epidural infiltration with lignocaine. And once the fascia is exposed, the fascia is cut along the line of the incision. And after we reach the lamina, this is what we want to see. We want to see the proximal lamina. We want to see the distal lamina. And once this is exposed, we use the Microscopic retractor. So it has a hook which goes towards the interspinous ligament and the blade which retracts the spinal structures. Then we again check the level at this stage. So we use a probe which is placed under the lamina to confirm that we have landed at the correct level. So we have to expose the L5S1 level. We are confirmed that this is the correct level. And this is the section what we have exposed. So we have retracted the paraspinal muscles towards the facet joint. And this is the intraoperative view. So as you can see, we can see the ligamentum flavum in the middle of the surgical site. The proximal lamina, that is the L5 lamina on the right side. The S1 lamina, the inferior lamina is on the left side of the surgical field. This is the spinous process of S1, the spinous process of L5. And we have pulled the interspinous ligament using the hook. And this is the facet joint, the medial part of the facet joint, which we have not exposed, but kept retracted by the retractor. So now our aim is to remove the ligamentum flavum, because it is an L5S1 level. We don't need to do a laminotomy. We can either go through the proximal part of the lamina or distal part of the lamina. So in that situation, I am using the periosteal elevator to detach the ligamentum flavum from the inferior lamina, that is the S1 lamina. So now I have made a small defect between the lamina and the ligamentum flavum. And I make sure that there is no adhesion between the thecal sac and the ligamentum flavum. So now I use a 2 millimeter upcutter. We can also use a 3 millimeter upcutter to make a small defect in the bone so that the ligamentum flavum is released from the inferior lamina. Now I pass a structure to protect the thecal sac as I cut the flavum. So I pass, this is the McDonald's or the Freer's elevator. Once it is passed between the ligamentum flavum and the thecal sac, now we can use a knife to cut the flavum. So I am using a knife to cut the flavum. And the rest of the flavum is removed using the upcutters. So as the flavum is cut, we can see the epidural fat coming out. So once the flavum is completely removed, now we can see the thecal sac bulging. So next step is to identify the nerve root. So we need to see the S1 nerve root now. So we can see the S1 nerve root. Yeah, that is the place where the S1 nerve is located. So the next step is to retract the shoulder of this S1 nerve root to identify the annular bulge. So there are few epidural veins which are engaged. Yes, so that is the annulus which is bulging, the white shiny structure. Now I'm going to incise the annulus along the line of the nerve root. So this is the contained herniation. So we have to incise the annulus to retrieve the herniated fragment. So we can see the fragment coming out. And we use a small pituitary forceps to remove the sequestrated fragment. So we removed one fragment. We can see more fragments coming out. So this is the stage of the sequestrectomy where all the fragments which have extruded from the nucleus pulposus are coming out. So I'm protecting the nerve root and the thecal sac with the small probe. And then whatever the remaining fragments, free fragments which are left inside the annulus are now removed using the forceps. We don't need to remove the entire disc. So now I use the probe to retract the nerve root and see whether the nerve root is adequately decompressed. And I use a small feeding tube to wash the epidural space and as well as the disc space. And that's the closure.
Are you through, Rishi?
Yes, sir, I am. The post-op protocol would be to mobilize the patient on the same day. The patient can be discharged in the day 1 or 2. They can resume normal activities by 2 weeks, and then we start core strengthening exercises for the back after 1 month.
Great. That was a great demonstration. Can you unshare your screen, Rishi?
Sure.
Dr. Chabra, just to warn you, you have half an hour left.
Yeah, sure.
I have unshared it, sir.
Sure. So, can you see my screen, everybody?
Yeah. Yes.
So, what is the role of endoscopic discectomy? Is it valid in all cases? Are there any specific indications? Arvind, would you want to elaborate on that?
Yeah, I think the best person would be Arun because he does endoscopic. I do the tubular.
Yeah.
So,
Arun,
so most of
we
the
are talking specifically about endoscopic. We may come into interlaminar and versus transforaminal later, but are there any specific indications or is it valid in all cases, endoscopic discectomy?
So to say broadly, endoscopic discectomy is valid in all cases. Having said that, I have been given the task of talking on showing both the techniques. So I think the talk will cover that which ones will be suitable for endoscopy and which one will be better for interlaminar.
Sure.
So shall I proceed?
No, just give me 1 minute, right? Yeah, you could proceed. In fact,
Dr. Chabra,
yeah. Pardon? Yeah, I will unshare.
Arun, please share your screen.
Yes, sir. I already shared. Can you see my screen now?
Not yet. Yeah, now it has started.
Okay. So Dr. Chabra was asking about the endoscopy. So because this is a slightly different and a new concept, just give me a couple of minutes to introduce what is endoscopy and how we call it full endoscopic disc surgery. So full endoscopy means that everything is done through the endoscope. It is a single channel working endoscope. So you don't have to do any triangulation like we do for arthroscopy, where you introduce scope from one side and a working instrument from the other. So as you can see in the inset, I have shown you the picture here. This is the actual endoscope which goes through external tube. The external tube's diameter is only 8 millimeter. So that means it is 8 millimeter size incision through which everything is done. And it is a coaxial vision. We see through that instrument and we introduce working instruments through the same channel which is shown in the inset, large channel. So you have a optics, you have one for irrigation, one for the irrigation fluid to come out. And this is done under constant saline irrigation. So the medium of vision is saline rather than air, as you just witnessed in microsurgery, or if you have to do a MED or a tube surgery, where you look at the anatomical structures through air as a visualizing medium. So this has a big difference and advantage because the constant saline irrigation washes the small droplets of blood that happen, and it gives you optics as they naturally exist of the structure. So you see visualization of the anatomical structures as they exist in the spine, not as a artificial hue, red hue. So moving on to minimalism, we started with microdiscectomy. Initially, it was good optics inside and smaller incision, which was further improved by the tube discectomy. And now it is the full endoscopy, which is kind of taking over. But it is not only the skin size, it is the concept of full endoscopy, which is different. That if you compare micro and MED, after you dock your cannula or tube on the lamina, the other of the surgical procedures, which Dr. Rishi very nicely elaborated, remain the same. That you have to do a little bit of laminotomy, you have to excise the ligamentum flavum, you have to visualize the nerve root, retract them, and do the discectomy. Whereas in full endoscopy, you do not have to do all these procedures. Even in the intralaminar one, you don't have to cut the ligamentum flavum completely. You have to only make a small hole, and your tube along with the endoscope goes inside the epidural space. You do your work because your optics are right sitting inside the epidural canal, and you come out after you finished. I'll demonstrate it in the coming few slides. To start with, this is an example of a about 42 years old male who had presented with a left-sided radicular pain for nearly 3 months, not settling with conservative treatment, and we can see a large herniation here. If we have to do a standard micro or a tube discectomy, we have to do the posterior approach and do a little bit of laminotomy, and then we will do the discectomy. But if I show you this MRI, this shows only the pathology has been taken out, the disc has been taken out, the nerve root is free, but we don't see any evidence of surgical tract. So that will probably answer the question that is endoscopy suitable or not, because if you can achieve this kind of a result without causing any surgical tract evidence, that should become the ideal treatment. Of course, we have to learn it, we have to master it, but if it is technically available and we can do it, it should become a natural choice. The full endoscopy is two types: transforaminal, as I already said, where we go from the side, which is intervertebral foramen, that is a natural opening of the canal, or the intralaminar, where we can go from the intralaminar window through the ligamentum flavum. So the transforaminal surgery is a totally different concept. We work anterior to the nerve root. We all know that the nerve root gets irritated by the disc herniation, which is lying anterior to the nerve root. So the disc is removed first and the neural tissue is visualized later. So that means the whole sequence of events, as Dr. Rishi mentioned, will get reversed. So you will dock your cannula right at the target, remove the herniation, and if you see the nerve root at the end, that means anything lying anterior to the nerve root is free, and that is why you will be able to see the nerve root. So that means that becomes the end point of surgery. It can be done under local or general anesthesia depending upon surgeon preference. Just to understand the concept, how it is safe, the intervertebral foramen has exiting nerve root which is lying in the superior half of the foramen, and the inferior half is free, which houses the Cambin's safe triangle. The name itself tells that it is a safe triangular three-dimensional area which is bounded medially by the traversing nerve root. The base is found by the upper end plate of the lower vertebra, and the hypotenuse is formed by the exiting nerve root. And this is how we can introduce our endoscope or the tube below the exiting nerve root very safely. The disc herniation also works to our advantage, because when we know the disc herniation happens, it pushes the thecal sac and the nerve root further dorsally, thus increasing the anteroposterior dimension of the Cambin safe triangle. So we can exploit this particular aspect to introduce our needle in this part of the herniation as shown here. Initial part of this surgery is done under fluoroscopic control because we have intraoperative C-arm. So we have to do a little bit of mental imagination that where are the neural structures lying in relation to the intraoperative X-ray. So our initial target of the needle will be at the superior articular process of the lower vertebra. Like for a L4-5 disc, it is the superior articular process of L5 where we touch the needle and hit the bone. That becomes our guide, and then we rotate the needle like this and then advance the needle further to reach the medial pedicular line, and in the lateral view we reach the posterior vertebral line. So these two match. That means that we are safe, the neural structures are further medial, and we can go inside and safely dock our cannula. The position of the patient is prone. You can choose a Wilson frame or a bolsters. I use bolsters. I do this surgery under local anesthesia. So initially, after putting the needle, we put a guide wire over the needle. Then we put a blunt obturator to dilate the tract. And over the obturator, we introduce our 8 mm beveled working tube. So it has a small bevel, which we use to retract the one part and visualize the epidural structure. So this is a surgical video. after we have introduced the cannula in the disc, inside the disc, just under the annulus, we start this video. So this is your orientation. 12 o'clock is dorsal and 6 o'clock is ventral. So these small tiny fibers are fibers of posterior longitudinal ligament, which we can shrink with this flexible radio frequency probe, and we can use this probe to cut and shrink both. So you can see we are shrinking and cutting the PLL fibers here. And once we shrink, we can cut them mechanically to visualize the disc fragment, which is going 12 o'clock, which is dorsally. So this is what I meant when you see the disc fragment first, and then you remove it. And once you remove, you will visualize the traversing nerve root, which is L5. And you can see the nerve root is free. You can ask the patient to cough and it will show free movement of the thecal sac or the nerve root. So once we see this, we just see are there any residual fragments, and if you're not, then you can come out and you can visualize, see the difference in quality of vision with the endoscope because of the constant irrigation. This answers your question, sir, that is it indicated for certain special cases or not? Transforaminal full endoscopy can work for paracentral, central herniations and almost all lumbar levels. Why I said almost, that means that there are few exceptions like L5S1, which I'll talk later. Up-migrated, extraforaminal, foraminal, down-migrated, almost all herniations can be handled with the transforaminal approach in expert hands, and multi-level herniations also. Now coming to the second technique, which is full endoscopic interlaminar, it has its role in certain anatomical situations, like it's a L5 herniation with a high iliac crest, or there is a up-migrated herniation at L5S1. If we come transforaminally, the exiting nerve root of L5 will come on our way and it can cause damage, or we may not have a good access to the fragment. So in that case, it is better to go interlaminar. If there is a highly migrated herniation, especially which is down migrated, so the inferior pedicle of, let's say it's at L23 or L34, the inferior pedicle of L34 at L4 will obstruct our transforaminal approach and may not allow, either we have to do a foraminoplasty to address it, or we can go interlaminar. Then we can use, if we have to advance to the next level of endoscopy, lateral recess stenosis and central lumbar stenosis can also be done with the interlaminar full endoscopic technique. Now, interlaminar, we all know that at L5S1, the interlaminar window is wide. At L4-5, the lamina starts coming slightly downwards and covers a part of the disc. And as we move higher, the lamina keeps coming down further, and it is a lot of bone is covering the disc. So we have to drill that part. So at L5S1, you do not need to cut any lamina, and you can simply go through the ligamentum flavum. But if it is at L4-5 and you choose interlaminar approach, you have to drill a little bit of lamina, and then you can proceed it as just like a L5S1. Now, this is a case example of a L5S1 left-sided herniation. You can see, and he had failed conservative treatment for nearly 4 months, underwent a nerve block also, did not improve, and then we chose to do a interlaminar surgery in this case, being L5S1. Initially, we don't have to do any needle here. We can just mark the incision under C-arm at the concerned disc space. We put the dilator, dock it onto the lamina facet junction, and once it is docked under lateral view, we introduce the working tube over it, and we withdraw the obturator. And immediately we can start the surgery with the introduction of the endoscope. Now, once we introduce the endoscope, we'll see a little bit of muscle and fat in between, which is cleared by endoscopic vision with the endoscopic pituitary. And this is the picture, first picture we will see that ligamentum flavum has been exposed. So once ligamentum flavum is exposed, we press the cannula tightly over the flavum and start cutting the layers of the flavum from medial to lateral. And as you see, we start visualizing layer by layer, we cut and we visualize the epidural fat. Once that is seen, we start moving the cutting instrument laterally till the lateral edge of the traversing nerve root is visualized. Once the lateral edge is visualized, we can advance our cannula further inside and we can rotate the bevel like this as I showed. Now, once you rotate the bevel from lateral to medial, it will protect the nerve root medially. You do not have to do any retraction with the retractor. You do not need any assistant. Your cannula becomes your retractor, and then you can cut the annulus under endoscopic visualization like this and create a small opening. Remember, all this is highly magnified because your scope is inside. So once you open up the annulus, you remove the fragment and you can see the nerve root is free, the shoulder, the axilla, both are very nicely decompressed. And now if you see, this is what I meant, that it is not only the size, but you can see the small opening in the ligamentum flavum. This is a 4 millimeter wide probe, and you can see this much is the size of the opening in the ligamentum flavum. So this is the difference between interlaminar endoscopy and the other posterior approaches. So if we compare various techniques of small skin incision, less collateral damage, if we compare it with my full endoscopy, it keeps on scoring. Small becomes smallest, less becomes least, good becomes excellent vision, better protection means best protection. And if we talk of variety or application of this technique, it's with the recent advancement in instrumentation like the drilling through the endoscope, we can actually apply this technique to treat a lot of stenosis cases. Now, this is the paper which I wanted to share with you about complications. So if this is lower complication, a technique offers lower complication rate, it is worth learning and mastering to give the maximum benefit to the patients. So it is the onus lies on us to learn it rather than just believing that a particular technique has been a gold standard technique. Thank you.
Thank you, Arun. Thank you for an excellent presentation.
I'll unshare, sir. Just a second.
Yeah. Quickly, is there any role of IDET, Dr. Shankar?
Personally, I don't have any experience, but I think it is gone out of the market now. Intradiscal electrotherapy is basically burning the annulus with the electrical probe. So
both this and percutaneous automated disc.
this used to be there 10 years ago.
Yeah, I have not withstood the standard.
Yes, they are out of vogue, sir.
They are out. So now this is a case again of a low back pain with severe left lower limb radiating pains in 6 months, walking distance 100 meters, no bowel bladder involvement. Patient was operated 3 years ago. Again, all classical signs of a disc prolapse, some mild neurological deficit. You can see the X-rays, dynamic X-rays. You can see the MRI, the CT scan. This was the previous MRI before the first surgery. Now, this is a failed conservative treatment. What would be the plan B? Traditional open discectomy, microscopic discectomy, or endoscopic discectomy? Quickly, Upendra.
Sir, first, I would like to see what are the symptoms of the patient. This is a recurrent disc herniation. I would like
recurrent
to
disc herniation with a failed conservative.
Yes. So this is a recurrent disc herniation with failed where we need to intervene. We need to know what are the actual symptoms of the patient. I would be seeing what to do. Disc is the which is on the, so the disc has to go as in a surgery we do. The other aspect I would like to ask the patient is how much is the back? Is he a smoker? Like to know, what are his activities? So based on all these things, if say the patient has significant back pain, there is a bit of modic 1 changes in the end plates also, I would be tilted towards a fusion in him, saying that the chances of him having a repeat surgery in the next 2 years is almost around 30% if we do only a discectomy in such a scenario. So we need to discuss patient to patient basis. In this, if he does not have any back pain, no other comorbidities, and his livelihood is fine, we can go ahead with the option of a discectomy, informing him that there is another chance of recurrence also. So complete counseling is very important for this, because we do a second discectomy, immediate pain is good. He has a recurrence, there is some pathology going on where go in for another surgery in the next 2 to 3 years.
Right. Arvind, do you agree or would you tend to differ?
Hello?
Arvind, would you agree with
Upendra? Obviously, he might have a recurrent disc, but I don't agree with the percentages that Upendra has mentioned. Many of these patients have just done a tubular discectomy in the absence of any indications for a fusion. And I don't see this higher recurrence. I'm not sure of any literature that gives this higher percentage of recurrence after a second discectomy.
Totally
if
agree.
you
There is no level 1 or 2 evidence, but there's enough evidence that you can go in again in a recurrent disc with an endoscopic discectomy. You don't need necessarily to go in for an open discectomy or fusion, but if there is instability, you may need to fuse. But people do tend to differ with their approach. So Pendra may want to fuse if there's significant back pain, but back pain could also be just because of the disc prolapse. So I think people can differ, but
fine.
may opt for fusion, but some may opt for just discectomy. In the interest of time, we'll move on. Shankar?
Fine.
Yeah.
Yeah, can you share your video on Wilson approach?
Okay, I will just go, I think, to this video straight. I think there's no time. And in the interest of time, I will go to my job was to talk on far lateral disc herniation, and I will show it's a Wilson approach I'm describing. So I will go straight to the video, otherwise we will not finish.
Actually, Dr. Chabra, can I interrupt here?
Yeah.
I wanted to say that there are lots of issues of disc prolapse which we have not been able to cover.
Right.
And I am thinking that rather than rushing through it and showing a paralateral disc herniation video right now when you have not shown a case of paralateral disc herniation, let us make this into part 1 of lumbar disc herniation, and we can continue this in a subsequent webinar.
Great. There is enough to be discussed subsequently also. If we can have a part 2, that would be great, because disc prolapse, there is enough to discuss still. So,
and it is one of the most common problems which is seen by the general orthopedic surgeon, and there is a lot to learn in this subject. So rather than burdening them with a very quick video and something, because Shankar has a beautiful small presentation on it also, which will be worthwhile for the audience to see. So my suggestion is that we could probably do this a second time. What do you think?
So since we are nearing 6, what would you suggest, Gautam?
I would suggest that we draw up a conclusions of the first session today,
right,
and then we go on to the next session, and we continue with lumbar disc herniation in the next session. There are lots of issues: acute cauda equina syndrome, large central disc prolapse, paralateral disc prolapse, upper lumbar disc prolapse, lumbar canal stenosis with disc prolapse, spondylolisthesis with disc prolapse, which need to be discussed, which we should do as a part 2.
Yeah, I agree with Gautam.
Yeah, I think a lot of people want to know what to do in a recurrent disc herniation also. If Dr. Chabra permits, I'll just share 2 articles here where
This is not the time for that, Upendra.
We'll discuss this next time. So
absolutely.
Just I want to make a point on recurrent disc, because Upendra made a point on recurrent disc. If I can make a point, 1 point.
Yes, sure.
Yeah. Basically, I think it is much overrated, and the surgeon sells the surgery rather than the patient needs the surgery of a fusion in recurrent disc. And I have a good number of recurrent disc prolapse, and most of the recurrent disc prolapse, unless there is significant evidence of instability or back pain, then I would normally do a second revision discectomy. And since I'm okay with microdiscectomy, and that's my favorite technique, I do a revision microdiscectomy.
To a large extent, Shankar, that depends upon who has done the previous microdiscectomy. If you yourself have done, then you know how much bone you have removed. But sometimes they are done by other surgeons, and they have removed excessive bone and leaving you no room to play when you are doing a revision discectomy. So that is my experience on this also.
Can I say something on that, sir?
Yes.
Yep.
So if you choose the endoscopic way, the problem of Dr. Gautam Zaveri about bone removal is circumvented, because you are going through a totally different area and you don't have to remove any bone. So that transforaminal endoscopic discectomy is an excellent tool to manage the problem of recurrent herniation if you are worried about bone removal or scar tissue.
Arun, what Gautam was trying to mention is, it depends when the patient comes to you whether you have done the previous
Right,
dissection
sir.
or somebody else has, right? So very often you'll get patients who've been operated upon elsewhere and who have had, there may be iatrogenic instability contributing to back pain, or there may be other conditions. So point well taken. We will start the next session with further discussions on recurrent disc herniation in order to conclude that, but we will also then move on to the other issues that Gautam had mentioned. We could not finish all the discussions in this time. I think the panel will agree, and the House also, participants also agree that this is quite a common condition, but we don't diagnose it with an MRI because many people will have changes in the MRI but may not have any clinical symptoms. So it is a clinical diagnosis. There may be presentation which may be typical, but there may be atypical presentations also. So you have to keep your eyes and ears open. But like with other orthopedic conditions, you have to rule out other differentials. For example, there may be the hip or the sacroiliac joint or other conditions which may be mimicking it. You may need radiological evaluation to substantiate your diagnosis. The vast majority of these cases do respond to a good conservative treatment, and surgical treatment or transfemoral steroids or steroids in any manner are required in a select few. So vast majority will respond to a good standard conservative treatment. However, what constitutes a good conservative protocol, we do not have a good evidence in that regard. Not many published studies in this regard. If the patient needs a surgical management, then there's no point in delaying the surgical management too much. If it's failed conservative treatment, or if there are quadriconal symptoms, you may need to proceed with a surgical management. If you need a surgical management, the option of the various techniques are there, but you should do what you are very well familiar with, but also pointing out that there are newer techniques available which help in less collateral damage, and which especially since you would need to follow up this patient for a long term, you may have less problems if the patient needs to be operated upon subsequently also. So we have a lot to discuss. We have to discuss about massive disc herniation, quadriconal syndrome, when to intervene, delayed neurological deficit when they present delayed. Do we need to still go in for a surgery? Intradural disc prolapse, when do we fuse in a prolapse intervertebral disc? And some of the other indications which Gautam mentioned. We hope to carry this discussion further in the subsequent webinar, and we would welcome you all for that webinar. Thanks for an interactive session to all panelists. We want to thank Ortho TV for giving us a privilege of reaching across to many participants across India. And a special thanks to Gautam, who has coordinated and has publicized and disseminated information about and got us all together so well for this webinar series. So look forward to having you there for the next webinar series. Over to Gautam to wrap up.
Thank you very much, Dr. Chabra. Thank you to all the panelists, including Dr. Shankaracharya, Dr. Arvind Kulkarni, Dr. Arun Bhanot, Dr. Rishi Khanna, Dr. Hadgaonkar, and Dr. Upendra for contributing their time to enlighten the audience. Before I give up, I'm going to summarize a few points, because on the basis of the questions which have been come to me through the Ortho TV network, lumbar disc prolapse, as Dr. Chabra said, is a very common problem, and the problem is that it has a lot of different presentations. The typical presentation is back pain, and then suddenly back pain goes away and pain comes down the leg. John McCulloch from USA described the clinical criteria for lumbar disc prolapse. These include leg pain, but it should be in a distribution of one of the nerve roots. There can be paresthesia, numbness or weakness, again in a radicular distribution. Nerve tension signs such as SLR, crossed SLR, or femoral stretch test may be positive. The diagnostic tests which are used typically are nerve tension and nerve compression signs. Nerve tension signs are SLR, femoral stretch test, crossed SLR, belt test, and slump tests. And the compression signs are obviously evidence of motor weakness, sensory loss, or loss of reflex. Among the tension signs, it has been found that the most specific test is the crossed SLR test, and the most sensitive is the bell test. However, the most frequently performed test continues to be the straight leg raising test. So the diagnosis of a lumbar disc prolapse is clinical, and the natural history, 80% of patients improve within 6 weeks, 90% improve within 3 months. If you wait longer than that, then there is only a 4% more of patients improve by 1 year. And therefore, 3 months is generally taken as the cutoff period after which non-operative treatment is stopped and surgery is recommended. However, there is some literature to show that prolonged conservative treatment may help. As we know, it helps in about 4% of patients. This is tried in patients who do not wish to have surgery. The problems of prolonged conservative treatment is that success rate after 3 months of relieving pain is significantly lower. There is a significant higher risk of chronic back pain and dissatisfaction with the outcome of the treatment, and there is a lower rate of return to work. When you decide on non-operative treatment, you do not require any initial investigations unless the patient has a neurologic deficit. The non-operative treatment, as Dr. Chabra and the team brought out very well, is a short period of bed rest, anywhere between 3 to 5 days. Non-steroidal anti-inflammatory drugs to reduce the inflammatory component, which is a major component, and analgesics, which can be either tramadol-like drugs or neuroleptics like gabapentin. However, the Cochrane database says that there is no role for oral or intravenous steroids in the treatment of acute disc prolapse. Epidural steroids and root block injections are given in order to tide over the crisis. Patients come with severe pain. You tell them you'll get better in 3 months' time. He says, how will I tolerate these 3 months of pain? So you're trying to give the patient some relief, and therefore these are useful in the first few weeks, not after months. Typically, foraminal epidural injections or root block injections are preferred these days because of their local action. However, there are some patients in which you have to give an L5 nerve root block, but there is a significant reduction in disc space, and therefore to enter the L5 foramen is difficult, and therefore here epidural steroids make a huge role. Activities even during the acute phase must be allowed within limits of pain. Exercises are started early in the disease process within limits of pain. However, you can advise the return to work only after the leg pain is significantly relieved. In the modern treatment of sciatica, there is no role of traction and belts. In my experience, 25% of the patient's pain resolves within 1 week. 50 to 60% with this kind of treatment resolves in 2 to 3 weeks. 80% of the pain is better in 1 month and 90% in 2 months. Then comes the timing, the question of surgery. When should you think of surgery? Well, as Dr. Chabra clearly pointed out, it's a shared decision between the patient and the doctor. What is it the patient wants? If there is acute cauda equina syndrome, it's an emergency. Try to operate within 24 to 48 hours. If there is a significant motor weakness, a cordyceps weakness, for example, or a foot drop, then early surgery. It's not an emergency, but as early as possible. For all other patients, operation is done based on a discussion between the patient and doctor. Typically, you wait for about a couple of months with non-operative treatment, and if then it fails, then you try to operate as early as possible, because it has been shown that after 9 months, even if you operate, the outcomes of the surgery may not be as good as original. What about neurological recovery? As Dr. Upendra mentioned, there are papers which suggest that whether you operate or whether you do not operate, the chances of recovery, neurological recovery, is about 50 to 70%. However, surgery does allow a slightly earlier and better quality of recovery than non-operative treatment. What about surgery? Which surgery should you do? I think we spine surgeons, when we talk to you people who are general orthopedic surgeons, we want to show we are great. And therefore, we talk about all these fancy surgeries. However, the outcomes of fancy surgeries and traditional surgeries have not been shown in literature to have a hugely different result over a longer period of time. Surgery is decided based upon the need. For example, surgery can be about bone removal. So you may do a fenestration where you don't remove bone or remove minimal bone. You may do a hemilaminectomy. This is done in patient. Fenestration is typically preferred for L4-5, L5-S1 or even L3-4 discs. It is done for typical posterolateral discs. If the disc is associated with a lateral recess stenosis or with a migrated fragment which has gone up or down significantly, or there are conjoint nerve roots, one will think of doing a hemilaminectomy. If, on the other hand, the patient has an upper lumbar disc prolapse, a large central disc prolapse, cauda equina syndrome, or a significant stenosis, one will think of doing a laminectomy. The goal during surgery is not to destabilize further by keeping intact the pars interarticularis as well as the medial facet joint. The goal of the surgery is, you must remember, is decompression of the nerve root and not simply a discectomy. How much disc to remove is always a question. As was discussed, the amount of disc removed depends on your thought processes. Some people prefer to only go for the sequestered fragment. This allows them to have a lesser operative time, less bleeding, less retraction of the nerve roots, less post-operative pain, and possibly less back pain in the long run. However, it does carry a higher risk of recurrence. On the other hand, most spine surgeons would prefer to not only remove the loose fragment, but to sequestrated fragment, but to explore the disc for any loose fragments that may be there. And some people also prefer to irrigate the disc under pressure so that any loose fragments which are marginally adherent come out and they can be excised. Fusion along with disc prolapse is a very rare surgery. It is done for proven iatrogenic, proven instability before the surgery, or if during the surgery you have had to remove an entire facet joint for some reason, as you would do in an upper lumbar disc or something, or a large central disc sometimes, then you would think of a fusion. What type of surgery? Is it wrong in these times to do an open surgery convention without microscope? You are working in a setup where there is no microscope, no endoscope, no total endoscopy. Can you do an open surgery? Certainly, as long as you believe in the principles of doing minimal damage to tissue as much as is only necessary, preventing instability, then you will still be able to do a good job for your patient. With most of these surgeries, the patients can be mobilized the same evening and sent home within a day or two. So remember, the message that ASSI wants to give all of you is that the decision is more important than the incision. Patient selection is the key to a good outcome. The mid-term and long-term outcomes are similar with different techniques. About 85 to 95% success in leg pain relief. The minimally invasive surgery may be more helpful in the acute stage with less pain, less blood loss, and less hospital stay. To gain more knowledge about these lumbar disc herniation, I would recommend that you buy the lumbar disc herniation monograph, which has been published by ASSI. It is available. You can buy it through the TM, which is our publisher website, or through Amazon. It is a comprehensive book on all aspects of lumbar disc herniation, from pathology, pathogenesis, clinical features, differential diagnosis, etc., to the various modalities of treatment and the outcomes of treatment. I will take this opportunity also to say that if you have any doubts and queries regarding this procedure of these webinars, please contact me, Dr. Gautam Zaveri, at my mobile number or email address, or write to our secretariat and the questions will be answered by one of us. I would like to take this opportunity to announce our next two webinars. The ASSI Master Series webinar is primarily directed towards spine surgeons. And the next webinar is on complex craniovertebral anomalies. It is on Sunday, June the 7th at 4 p.m. And we have a galaxy of experts who are world renowned in this procedure, not only known in India, but world renowned. And I would request all those who are interested to join us, and I'm sure you'll have a treat. The next Pro Series webinar was tentatively scheduled for June 21st, was lumbar canal stenosis. However, it seems that after today's webinar, we may continue the next webinar with disc herniation and probably do the lumbar canal stenosis webinar in July. We will keep you updated about this through our constant WhatsApp messages to decide what is going on. With that, I again thank all the panelists and specifically Dr. Chabra for helping us out. And I thank all of you for joining us on this Sunday. Thank you.
Thank you.
Thank you, everyone. Thank you.
You're welcome.
I think that was a very